Hi, I'm BrooksCash. I am Chief of Gastroenterology, Hepatology, and Nutrition and Professor of Medicine at the University of Texas Health Science Center and McGovern Medical School in Houston, Texas at the Texas Medical Center. It's a real privilege to have been asked to speak at this conference. I wish we could see each other in person, but one of my talks is actually going to cover the common mistakes to avoid in nutrition and GI. So with no further ado, let's go ahead and jump into that. So the first common mistake that I wanted to highlight was a failure to embrace dietary therapy for patients with irritable bowel syndrome. I think we all recognize that food plays an important role in the generation of symptoms of IBS in our patients, and there's data that suggests that up to 60% of patients with IBS blame food in some way, shape, or form for their symptoms. And there's a huge interest on the part of patients to actually use diet to treat their illness. I think they view it as a much more natural way to treat their IBS, but also I think it's a way for them to retain control as well. And control is very important to these patients because they often, especially those with diarrhea, which is who we're really usually talking to dietary therapies about, they have a sense of loss of control because of the fecal urgency and urge incontinence that they can sometimes experience. So I think that's a self-empowerment issue that really lends itself to dietary therapy. And there are multiple mechanisms by which food can induce symptoms, not only carbohydrate maldigestion, but also certain foods may actually be antigenic, not just gluten, but other constituents of wheat, rye, and barley and some of the grains that we eat. And there is randomized controlled trial evidence for efficacy of dietary change in IBS. So I think it's really important that we do embrace diet as a potential therapy for IBS patients. And if we don't engage in this type of therapy, then I pretty much can guarantee that our naturopath colleagues will. And I think it behooves us to be well versed in these types of treatments. So the most common dietary strategies for patients with irritable bowel syndrome are shown here. They include gluten-free diet or gluten-restricted diet if it's not completely gluten-free, the low FODMAP diet, all of us have heard of that now, and then other exclusion diets based on antibody or leukocyte activation testing. Now, the ACG guidelines on irritable bowel syndromes, and in this case, dietary therapy specifically, did make some statements. And the ACG, and this is the guidelines that came out with Alex Ford as one of the lead authors, suggested a low FODMAP diet for overall symptom improvement in IBS. That was a weak recommendation with very low levels of evidence. And they actually suggested against a gluten-free or exclusion diet based on antibody or leukocyte activation tests, again, weak and very low qualities of evidence. My own personal opinion is that I think if somebody wants to go on a gluten-restricted diet, there's likely no harm in that. The data on nutritional deficiencies with regards to restricting gluten are really very scant and probably non-existent based on what I've seen. So I don't think it's inappropriate to try some of those things. So, but they're often done incorrectly, and that's really what I wanted to focus on today. And this is a busy slide, but it looks at low FODMAP diets and other diets for irritable bowel syndrome, and really across the board have shown very promising results, and not hitting the ball out of the ballpark per se, but significant improvement in some patients by adopting a dietary therapy, specifically low FODMAP diets. And there is, I think, very convincing evidence from multiple different countries and clinical practice settings, Canada, the UK, the US, Australia, of course, where FODMAP got its start, that show that this approach can help patients in terms of their abdominal pain, their diarrhea, their urgency, their gas, their bloating. But it's important to recognize that we need to do this in conjunction with a dietitian. So, the first step in a low FODMAP diet is to determine the role of FODMAPs in the patient's genesis of their symptoms, and also to educate them about FODMAPs and where they are in food. It's also important to recognize that a low FODMAP diet is not meant to be a long-term option. If patients don't have any benefit from this type of a diet, then it should be stopped and they should be reinstituted on a standard diet, or perhaps embark on a different dietary therapy if they're interested in that. Gradually over time, if patients do respond to this, different classifications of food, just like a 6-food elimination diet for eosinophilic esophagitis, are reintroduced into the diet. Now, when we do this re-challenge, the goal is to identify those sensitivities of certain FODMAP subgroups and find a balance between symptom control as well as expansion of the diet. And the process typically will occur through one challenge at a time, a symptom response. There's a 2 to 3 day break or washout period in between each challenge. And this is why having a dietitian manage this as opposed to trying to do it as a clinician is critically important. They know the right questions to ask, but they also have the time to be able to follow up with the patient this frequently. And finally, personalization of the FODMAP diet to hopefully get to a point where there's very mild restriction only. The patients don't have a dramatic effect from food-related quality of life and having to be overly restrictive, worrying about nutritional inadequacies or negative impact on the microbiota, which is still theoretical, but also empowering the patients that they have control with regards to what they put in their mouth, and then thinking and hopefully relating to what their GI symptoms are. So this is just an overview of the FODMAP dietary program. Phase 1, avoid all foods high in FODMAPs. It is an exclusionary diet. It's a very tough diet to do. If patients don't have a benefit within 2 to 6 weeks and they are adherent, you abandon the diet, you move on to something else. If they do have benefit, then you gradually step down in those restrictions according to tolerance and then personalize it. So really best if dietitian delivered. So some outcomes with regards to personalized FODMAP diets. 6 prospective studies have been done, up to a year and a half in terms of follow-up within reintroduction. 75%, when you look at all this data combined, 75% of these patients have been able to reintroduce and personalize their diet with an overall sustained symptom response in 57 to 82%. And I think that's one of the myths with regards to FODMAP is it's overly restrictive, which it is very restrictive, but that it's a long-term restrictive type of practice, which it really isn't. And there is no evidence of harm. So we are starting to get those long-term data that we want with the low FODMAP diet. And this again just reiterates that symptoms are improved, especially even as we move into the phase 1 and later stages of reintroducing food. Now, are there predictors to a low FODMAP diet? Not really. We just don't see anything that's going to tell us whether or not patients are going to do well. I do think that if you don't have a motivated patient, that you might as well just move on to something else. There are some exciting things that are coming down the pike, possibly looking at breath test results or maybe even volatile organic compounds that may allow us to predict who would respond to a low FODMAP diet. But currently our bowel habit patterns and our traditional breath test results really don't have much bearing in telling us whether or not somebody's going to respond to a low FODMAP diet. Finally, the question with regards to low FODMAP is, do you really need a dietitian? The resounding answer is yes. Most of the evidence, when we do tout the efficacy evidence for a low FODMAP approach to IBS, has come from settings using dietitians. So it's biased in that fashion. Maintaining adequate nutritional components is really very important, and a dietitian's best position to be able to make sure that patients are getting adequate calcium and fiber. That reintroduction phase that we went over, it's a bit labor intensive. And then finally, dealing with practical issues, learning and teaching how to read food labels, meal planning, those sorts of things. So really do need to have a dietitian, and that dietitian should be adequately trained and equipped to advise in regards to a low FODMAP diet. And here's actually some data looking at the effects of not using a dietitian with regards to response with low FODMAP, as well as other types of diets in patients with inflammatory bowel disease, celiac. You can see that when we look at patients or situations where no dietitian is used, the chances of success are dramatically lower than when we use dietitian. Now, these are low numbers, but I think they're really compelling, and most of them are actually statistically significantly better when a dietitian is used. So that's really critically important. One of the perhaps tendencies for many of us, and this is certainly what I did early on in the FODMAP lifetime when we didn't have dietitians available at Bethesda Naval Hospital where I trained, is I would tell patients to go on to Google and look at what constitute a low FODMAP diet, educate themselves, and try to adhere to that diet. And I would just encourage you not to do that. The information with regards to diet is poor. In terms of these communities on the internet, the quality is poor, the readability is poor. There's a lot of fringe stuff out there as well, and not necessarily concurrent recommendations that a dietitian in mainstream medicine would give. So beware, Dr. Google is what I'm saying. And then finally, teaching the diet without a dietitian, really much better to do with a dietitian who has that training. No one single piece of paper can actually teach this diet. It's a very iterative process, and we just don't have the bandwidth as clinicians to do this. Now, I'm going to segue a little bit to stay with regards to IBS, but also think about diet in a different way. We often consider, as I mentioned, 60% of patients identify diet as bothersome to them with regards to their IBS symptoms. And we often think about carbohydrates as being particularly bothersome to certain people, but we usually think of that in the context of things like lactose intolerance. I think we need to broaden our horizons a little bit and think of other carbohydrates that patients may be intolerant of. And one that's really rising to the surface is sucrose and starches. And so I'm going to introduce the concept of CSID, or I really like to call it SID, S-I-D, and that's sucrase isomaltase deficiency. There is a congenital form, that's the CSID acronym, congenital sucrase isomaltase deficiency, but there's also an acquired form. Now remember that sucrose isomaltase is the primary disaccharide that actually digests most dietary sugars and starches, which constitutes in the Western world and in the US in particular, at least half of what we traditionally eat. Now, this is expressed just like lactase throughout the brush border membrane. It tends to be at the tips of the villi, and there are more than 30 different CSID variants that have been found in people previously diagnosed with irritable bowel syndrome, and that's the congenital form. But there is an acquired form, as I mentioned. So here's just a cartoon showing normal carb digestion. And what I'm showing you on this cartoon is that simple sugars just get directly absorbed, but in the case of more complex disaccharides like sucrose, it requires these enzymes to break those sugars down into monomeric forms like fructose and glucose, which then can be absorbed. And this is done starting in the mouth with alpha amylase, which starts to help break down maltose, but also then later on in the brush border enzymes in the small bowel. And sucrase isomaltase deficiency, if it is present, will result in symptoms very classically like irritable bowel syndrome and bacterial overgrowth, or perhaps even lactose intolerance. And that is that these more complex carbohydrates, as they reach the distal small bowel and they reach the colon, start to get fermented. That creates gas, that creates an osmotic pressure, it creates other organic compounds, which then can cause IBS-like symptoms or abdominal symptoms, typically diarrhea, bloating, urgency, abdominal pain. So let's look at a little bit more in detail with regards to some of the genetics. This is a study looking at patients who were previously diagnosed with IBS with diarrhea. And what you basically see here is not only in those patients, but also patients with chronic diarrhea, there's about a 4% prevalence of sucrase isomaltase genetic variants that are shown, coding for deficiency. We think, based on pediatric data, that the prevalence of true CSID may, in symptomatic kids at least, is typically about 9%. We're finding some similar numbers with regards to adults, but again, it's a little bit more difficult because there is also the concept of an acquired sucrase isomaltase deficiency. This is actually some of that data that I just quoted, 9% in this study, and this is over 27,000 biopsy samples. That's one of the issues with regards to sucrase isomaltase deficiency, is there are about 5 different tests that you can do to try to diagnose this condition, and none of them are terribly well validated. The gold standard actually is disaccharidase measurement based on biopsies, and this study showed a 9% prevalence of that. So things to think about when you're considering sucrase isomaltase deficiency would be the acronym FLIP, so frequent symptoms, lifelong symptoms, and these are typically IBS-like symptoms. Postprandial, so related to meals, usually 15, 20, 30 minutes after eating. Loose stool frequency, bloating. Patients will often find that if they avoid carbs, they feel better, and they'll say, well, it's just because of my carb-restricted diet. Well, it may actually be because they have a sucrase isomaltase deficiency, and they may even be on the thinner side with low BMIs. So think about those types of symptoms. And also, when you have patients who fail the low FODMAP diet, think about CSID, because a low FODMAP diet is not a low sucrose or starch diet. And Bill Shea and Shanti Eswaran have shown that among people who failed their low FODMAP diet in their US trial, when they actually looked for sucrase isomaltase deficiency, they did find it more commonly in those failures compared to patients who responded to the low FODMAP diet. Also recognize there is a treatment solution for sucrase isomaltase deficiency. Just like lactase deficiency, you can give an enzyme replacement. In this case, it's saccharosydase oral solution. This is derived from Saccharomyces boulardii and is a sucrase replacement. It does not replace the moiety or the enzyme that breaks down starch. You should use this in conjunction with dietary therapy. It should be a sucrose restricted diet. You do that first. You can then institute saccharosydase, and if you need to later on, you can address reducing starch as well. And again, this really should be done with a dietitian. So let's move on to diet and another aspect. We're actually going to move up in the GI tract, talk about EOE. This is just the algorithm that was published in 2018 with regards to treatment of EOE. And what I wanted to point out was dietary elimination is very high up. It's the first step in the treatment algorithm, right along with topical steroids as well as PPI therapy. So let's talk about that dietary approach to EOE. And I think we don't overlook this, but I think we sometimes resign ourselves to it being difficult to do, or our patients won't be compliant. I've actually found exactly the opposite. I think our patients are excited not to have to take medicine. So this may actually be the best therapy for EOE. Obviously, the rationale is that there are food allergens that may contribute to the pathogenesis of EOE. And there is a 6-food elimination diet. There's a number of other recipes. There's a 4-food elimination diet, a 2-food elimination diet, but the classic for EOE is the 6-food elimination diet. And you can see here the classes of foods that you avoid. So nuts and legumes, shellfish, eggs, grains, especially wheat, and then milk. So recognize that, and soy as well. So recognize that that's what constitutes the 6-food elimination diet. And it really does quite well when we look at histologic remission. Now, that's not the end all be all. We should also look at symptoms, but we tend to think of histology as driving symptoms. And it really does quite well, nearly as good or almost really as good as an elemental diet, or very closely to that. Nobody wants to do an elemental diet as an adult, of course, and really not even as a kid. So recognize that there is good data suggesting and showing that a 6-food elimination diet diet does work in EOE. As I mentioned, there's a 4-food elimination diet, a 2-food elimination diet. All of these have been looked at. Now, the 6-food elimination diet does better. That doesn't mean you absolutely have to start with that. You can be a little bit more creative and try a less restrictive diet, and you may get about 50% of patients who have a response to that. Perhaps if that's combined with some sort of medical therapy like PPIs, the response may even be greater. So what this may allow us to do is actually even reduce the number of endoscopies that we do. What about a 1-food elimination diet? Well, there's a randomized controlled trial that was published this year, or last year, I'm sorry, in DDW, looking at a 1-food elimination diet compared to a 4-food elimination diet. This is a pediatric population, so not necessarily exactly what we would study or the types of patients we see in our clinical practices for the most part, but it actually showed relatively good results, very equivalent in terms of the histologic response. The total symptom score was greater, the change, in the 4-food elimination diet compared to the 1-food elimination diet. So, you know, while the quality of life was improved with a less restrictive diet, based on the symptom score, at least on this pediatric data, I think it's provocative. I don't think we're ready for a 1-food elimination diet just yet. Finally, let's also talk about gastroparesis. And another common mistake is not starting with dietary modifications in gastroparesis. I'm giving another lecture at this conference on gastroparesis, so this will be a bit shorter, but recognize that lifestyle modifications, especially dietary changes, are really an invaluable cornerstone for symptom relief for patients with gastroparesis. And what I mean by that is smaller, low-calorie meals that help decrease gastric emptying time compared to high-fat, high-fiber, larger meals. So our guidelines for gastroparesis all universally recommend frequent small meals, becoming grazers, if you will. Liquid meals can also play an important role in these patients because liquids still do empty relatively well in patients with mild to moderate gastroparesis. So encouraging patients to follow those recommendations is critically important. What about Pegtubes in gastroparesis? Well, this is another mistake. Now, sometimes, in fact, we see this quite a bit. Unfortunately, there is no proven role for a Pegtube for nutrition or decompression in patients with gastroparesis. It is something that's done. There's not great data that shows a tremendous amount of support in terms of improved outcomes. We also will see PEGs placed. TPN is not appropriate for patients who have an intact small bowel. So that's another concept that's a frequent mistake with gastroparesis. And patients will push you to try to give them a central line or a PICC line and use some form of non-enteric nutrition. This really should not be done. You should use the gut when at all possible. Now, there will be certain circumstances where a PEG, or more commonly a PEG, will be placed. That may help patient outcomes, but there's no strong data from randomized controlled trials that show that that's a especially helpful thing to do. So do keep in mind that really, unless it is a last option or a final solution, not really appropriate to do early on. Over-reliance of diet and GERD, that's another common mistake with regards to diet and nutrition. You know, we commonly will recommend patients try to diminish their symptoms with diet. And there is some benefit in terms of weight loss and other symptoms, some of which we've already talked about, but restrictive diets are not terribly helpful for GERD. There are some common things that we can recommend, which is such as lowering alcohol use and carbonated beverages, but there's really no level 1 evidence to support the use or elimination of spicy foods, coffee, citrus, or fatty foods in patients with GERD, and certainly no evidence that doing so will actually reduce or heal erosive esophagitis, so a more advanced form of GERD. And actually, some of these dietary components can be associated with dyspepsia. So it becomes very muddy when patients eliminate some of these things and their epigastric symptoms get better. Was it an improvement in their GERD, or was it an improvement in their dyspepsia? We just don't know. There are some lifestyle interventions that can be helpful for GERD. The most important is weight loss. Head of the bed elevation can sometimes help symptoms and has been shown to improve esophageal pH data. But again, when you look at the dietary therapies, there's not any well-done studies. There's no evidence that eliminating these types of foods actually is going to be helpful in your patients with GERD, but we tend to over-rely on that. Finally, I want to talk about post-bariatric patients, and another mistake is failure to monitor and supplement nutritional deficiencies. These patients have a very high incidence of nutritional deficiencies, especially those patients who undergo restrictive therapies, and we are seeing an increased incidence of bariatric surgeries. And recognize that these nutritional deficiencies are not only common post-operatively, but they're common pre-operatively. So while we would love to say it's the surgeon's responsibility to follow these patients and their nutritional status, unfortunately, it often falls to us, and we need to take care of the patient. So some of the more common deficiencies that we should be thinking about in these patients: iron deficiency, hypovitaminosis D, B12 deficiency, B1 or thiamine deficiency up to 20%, vitamin C deficiency, and zinc deficiency. So this should be included in the baseline evaluation as well as ongoing evaluations post-operatively. When we look at the post-op nutritional deficiencies, we see increases in iron deficiency with anemia, B12, folate, calcium, and vitamin D, and we need to monitor those fat-soluble vitamins, A, D, E, and K. I've already mentioned D. In terms of water-soluble and essential minerals, recognize that we also should follow thiamine, magnesium, zinc, copper, and selenium levels, and look for protein malnutrition as well. All of these should be monitored, and this is from guidelines that were published recently, at least every 3 months for a year, then every 6 months for a year, and then annually. So once patients are out more than a couple of years, we can just measure these annually, but at least early on, we should keep a close eye on these nutritional deficiencies. So let's just summarize here. What I've gone in rapid fashion is 10 mistakes to avoid in nutrition and GI. Number 1, we talked about failing to embrace diet as a treatment for irritable bowel syndrome. Number 2, we talked about some of the errors and shortfalls in terms of implementing low FODMAP diets correctly or incorrectly, and then failing to use a dietitian for low FODMAP, failing to recognize sucrase isomaltase deficiency, failing to consider starch as a source of abdominal symptoms, thinking about dietary therapy for EOE just for pediatric populations. It really does have a role in adults, avoiding diet modifications and gastroparesis, really a key role in those patients, putting in gastric tubes in patients with gastroparesis, over-reliance on dietary elimination for GERD, and then finally not monitoring or replacing vitamins and minerals in patients who have undergone bariatric procedures. So with that, I'll stop. I want to thank you all for your attention today, and I'm looking forward to answering any questions. Feel free to email me or contact me if you do have any questions with regards to these after the conference as well. Thanks very much.